So hello, everyone. I want to thank you for this opportunity. My name is Dr. Matthew Cooper. I'm a kidney transplant surgeon from the MedStar Georgetown Transplant Institute in Washington, D.C. And so now let's look at what we do to screen somebody for transplant. I took these slides right out of our education criteria. And this is the standard stuff that we do, not surprising, screen for cancer. And I want to point at that bottom line. I added the red part to it. It's dental evaluation if indicated. That's actually the learning point for me was we had this in our presentation, if indicated. Well, of course it's indicated. We're telling people they shouldn't have cancer and we need to do all these screening tests to worry about complications for transplant, and that's on the next slide. But we actually put if indicated. I'll tell you that we've since taken that out after I put this presentation together, because this is what we're looking for, is to try and figure out how do we prevent the problem? How do we assure that the risk of immunosuppression is not going to create a successful transplant into a very poor outcome? Because as the bottom point there says, even with minimal inflammation, I think everybody on this presentation would appreciate that adding immunosuppression is a horrifically poor outcome. So again, making sure that we are integrating oral care and good dental care prior to in the induction of immunosuppression is incredibly important for our patient population. In fact, that's been demonstrated in multiple studies. I pulled one out here that shows that patients that present with a single dental problem had almost 7.5 times more chances of being hospitalized the first 2 months after transplant. So this has significant problems. So our job is to figure out what are absolute barriers and what are remedial barriers, because we're just limited by time and space and energy. But the remedial barriers to and beyond transplant are the real ones that again demonstrate the importance of successful integration, cooperation, both in-house and utilizing folks outside of our institution. And again, demonstrate the integration of how oral health and dental clearance is incredibly important in our real-time evaluation if we're to provide patients with the success of transplant. This is interesting data that was supplied to me by Dr. Coffey that has not been published. I wish it was. And it shows that there's a significant number of patients that are actually not listed simply because they have dental issues. Not simply minimizing it, but you'd think of all the things that we should be able to find an answer for, that would be one of them. And this is part of the problem, that the significant number of those patients also require assistance financially or even pro bono in order to be able to achieve clearance for transplant. And we all have examples of how that can go in both directions poorly. Either they never get cleared and so they never get transplanted because they can't afford it, or they go into significant debt in order to be able to get listed for a transplant. And neither of those, of course, makes sense.
Hello, I'm Dr. Gwen Nichols, the Chief Medical Officer at the Leukemia Lymphoma Society, and I'm very pleased to be speaking to you today about putting patients first and the critical collaboration that we need between oncology and dental professionals. Anne-Marie has a slightly different story. She's being treated for lymphoma, and the treatment seems to be going smoothly, and she appears to be responding. But unfortunately, her medical oncology team didn't do a thorough oral evaluation before starting very strong chemotherapy to cure her lymphoma that causes neutropenia. She's now day 14 after her chemotherapy and has fever and hypotension and has to be admitted to the hospital. She started on empiric antibiotics, and 48 hours later, we find out that strep viridans is in her blood. That causes the team to inspect her oral cavity, where they find thrush, poor dentition, and periodontal disease. And this is the likely source of her infection. It can be successfully treated, but it delays her next treatment due to urgent need for dental work. And this can impact her chance of being cured of a curable lymphoma. In Anne-Marie's case, oral pathogens are common isolates of chemotherapy-induced neutropenic fever and sepsis. And these can range from fever to hypotension and even death in the hospital. Radiation is a critical part of cancer therapy. Carcinomas of the head and neck, lymphomas, and radiation, particularly to the head and neck, can leave patients with chronic xerostomia, gum disease, and tooth decay, as well as osteonecrosis of the jaw. Attention to oral health before radiation starts and afterwards to monitor for these complications really is crucial for successful therapy and quality of life after therapy. And radiation oncology teams and dental teams need to discuss coordinated care and not just, please provide me fluoride gel, but a real discussion about what's expected given the fields of radiation that the patient is going to receive. Another area that I always talk to my dental colleagues about is the use of bisphosphonates. Bisphosphonates are not only used to treat osteoporosis, but they're also used in several types of cancer treatment, including and especially multiple myeloma. Osteonecrosis of the jaw, while rare, is a serious complication of bisphosphonate use, and it may present, obviously, to a dental professional. Anticipated dental procedures should be done before this therapy is started because dental work can precipitate the osteonecrosis of the jaw. Another critical reason for good communication. A collaborative approach between teams is critical for patients during cancer therapy, and there really should be a personalized cancer dental care plan developed. And this should not start as a crisis in the middle of treatment. This should start before treatment. Patients should be referred for oral evaluation and treatment of conditions that could lead to systemic infection and obvious complications and delays in life-saving treatment. Pre-therapy evaluation and stabilization and surgery, if it's required, needs to be timed between the dental and the oncology teams. And one thing that's so critical that oncologists, I know I'm guilty and others are, of forgetting that the fit and hygiene of prostheses needs to be considered before, during, and after, especially when patients may lose some weight and have a different fit of their dental prostheses. During the treatment, incredibly important to monitor and treat for complications of therapy, mucositis, xerostomia, fungal and viral pathologies of the mouth. We need to be treating them together, and the timing of any treatment needs to match the timing of the patient's blood counts for the patient's safety's sake. And finally, afterwards, we need to manage together post-treatment oral complications. Dental caries after cancer treatment can be seen in more than 25% of patients. And there is dysgeusia, there is xerostomia. These are all things that can affect the quality of life of survivors of cancer treatment. And if we think that being nourished and healthy after cancer treatment is important, and I hope all of us do, we need to make sure that oral health is part of that because it's such a critical component to keeping people healthy.
In my perspective, we're going to be talking about cancer care and the needs of people who have cancer, have survived cancer, and preventing cancer, and the impact of good oral health. I want to give some examples of how we can be integrating oral health during cancer treatment. We want to make sure that patients have dental clearance before they begin their treatment, a thorough dental exam with an understanding of what dental work needs to be done and what are potential areas for bacterial infection that may only be exacerbated by chemotherapy-induced neutropenia and vulnerability to infection. We want to collaborate to manage these treatment-related side effects such as dry mouth, mucositis, and dysphagia, which can be very devastating for patients. Because if we don't do this together, patients will suffer because they will not be able to eat. They will not be able to drink enough fluid. They may have more ulcers and mouth sores and an overall poor quality of life. It is better that we take care of these oral issues before we start treatment and work together during treatment. And it's even more cost effective, as pointed out in a recent article in the Journal of Clinical Oncology, to take care of oral health issues before treatment and during treatment than to wait till later when we have devastating effects such as osteonecrosis of the jaw. In addition, there are late effects from cancer treatment. When the head and neck has been irradiated, there are possibilities years out from treatment of dental decay or dry mouth from damage to the salivary glands or difficulty swallowing due to the surgery and or radiation. There may be lymphedema and swelling causing problems with dysphagia as a result of radiation and long-term damage to the lymphatic channels. The possibilities of osteonecrosis of the jaw from bisphosphonates and or radiation treatment are an ongoing, permanent change that needs to be assessed and followed. And we need to make sure that we're scheduling our treatments and oral therapies and dental work so that we are aware of where radiation might have damaged tissue and make sure that we're protecting healthy tissue. These are some of the other side effects where we all need to collaborate and where a team is required in order to minimize the suffering patients have, but also to improve their overall health, nutrition, and hydration.
Which sector, which coverage sector, Medicare, Medicaid, or commercial insurance plans do you think is the first place to go in presenting this cost effectiveness argument?
Well, I'd say Medicare is the first place to go, but I'm biased because cancer is a disease of older Americans, right? So maybe Dr. Cooper might have a different thought because the transplant population is generally younger.
Well, I agree with you, Gwen. I think Medicare is the direction, and as a specific sort of follow-up to your example, over the last 20 years, we were actually fighting Medicare, who currently paid for immunosuppression costs only out to 3 years, and then that support went away. We were able to demonstrate the cost savings of paying for immunosuppression indefinitely versus returning to dialysis secondary to graft failure, and the numbers were able to demonstrate a cost savings of over $50 million in over 10 years. And so with that information in hand, I presented to Congress the data, and again, sort of a nonsensical argument. The money saved certainly was worth the investment. And the same thing could be said for oral health and the ability to keep people, first off, get people transplanted and to keep them safe following transplants. I'm sure we could be able to do a similar analysis that demonstrates the cost savings to invest in good oral health pre-transplant or pre-cancer therapy and pre-everything that will, again, offset any costs that would enable this to happen.